Welcome back to the medical report. For those who are just tuning in, we have today Dr. Matthew Shaeffer, who is a board-certified rehabilitation and physical medicine physician who specializes in low back pain. And he has gone through the first session explaining the anatomy of the low back and some of the parts of the back that can cause some trouble. So what we're going to talk about first in this session is some of the diagnostic studies that might be done in order to help him decide which therapy might be best for the individual. So Dr. Shaeffer, can you proceed with the workup?
Certainly, Dr. McCabe, thank you. So many of you, I'm sure, have experienced low back pain at one point, and some of you maybe the chronic low back pain. And when you see the physician in the office, the first study they usually go for, the first diagnostic tool we want to see is the X-ray. And the reason we go with the X-ray is because we get a good idea of the bones. We can see if there's any fractures in the vertebrae or the bones of the spine. We can see if there's arthritis in the lower joints or facet joints of the spine. We can see if there's a slip, if one bone has slipped in front of the other. What we can't see is the soft tissues. X-ray only images bones, not the discs or the nerves or the muscles. So if we have an X-ray and we're not certain the cause of the chronic low back pain, nowadays we jump rather quickly to the MRI, which is magnetic resonance imaging. And this is a diagnostic tool that gives us a picture without exposing the patient to any X-ray radiation. In fact, it's just a big magnet. It's pretty amazing. And the MRI is very helpful in looking at the discs and determining if there's a tear in the disc or a herniated disc. It's helpful in determining if there's a nerve being compressed, or if the entire or part of the spinal canal is narrowed. And that word for that is stenotic or spinal stenosis. So the MRI is really instrumental in figuring out the cause of the disorder that's causing chronic back pain. Now MRI has come a long way in its, what now, about 30 to 35 years existent. It really came out in the early 1980s, and since that time the images have gotten sharper and better, and we've had to rely less on some other diagnostic tools that we used to use, which are a little bit more uncomfortable. And one of those studies is called myelography, and that's where the physician would take a needle and place it in the epidural space and inject, or actually place it below the epidural space and inject a contrast into the spinal canal. And by looking at where that contrast flows, we can determine if the canal is stenotic, if nerves are getting pinched, if there's discs pressing on the structures. Excuse me. So most of the time we don't have to do that study anymore, but in certain circumstances, such as after having multiple back surgeries, we still may need to do that myelography study. Many of you have heard of the CAT scan, and the CAT scan is another diagnostic tool that we commonly use. With the improvements in MRI, most of the time we'll only order a CAT scan if the patient has a pacemaker or cannot have MRI because of having small metal fragments near structures that we don't want the metal to move and touch. Other reasons why we use a CAT scan is if we're suspecting that there's a abdominal or pelvic soft tissue cause of chronic low back pain, such as having kidney stones or gallbladder issues or gynecologic problems. The CAT scan is often used to image those structures. In addition to the X-rays, MRI, CAT scans, which are really pictures of the spine, once in a while we'll have to use a really sensitive study called a nuclear bone scan. And a nuclear bone scan is a study in which we inject contrast into the arterial system, and if there's any abnormality or active abnormality in the bones of the spine, the contrast will be taken up by those bones, and it will emit a signal that we can pick up on an X-ray. And this is how sometimes we find those really small fractures or really small lesions or tumors in the spine. So that's the nuclear bone scan, which we do order on occasion. Now, those diagnostic tools are pictures of the spine, and they don't show pain or inflammation, and they don't show nerve injury or irritation. One of the other common diagnostic tools that we use is called electrodiagnostic studies. And in short, you may have heard of them as the acronym EMG, which stands for electromyography. What we do in this study is we stimulate nerves in one location, and then we pick up the signal in another location. And we know, during this portion of the study, we know that nerves are supposed to work or activate or conduct electricity in a certain manner, at a certain conduction velocity and in a certain time. And it's helpful to determine if the nerve is injured. It will slow down or in some cases speed up. The other portion of the electrodiagnostic workup is truly the electromyography, which is a needle study where we put electrodes in various muscles in the back, buttocks, and legs, and if the nerves that are supplying those muscles are not functioning correctly, the needle or electrode will tell us so. I like to think of the electrodiagnostic study as in this manner, and this is how I describe it to my patients. If the MRI or X-ray is a picture, it's like taking a picture of a telephone, and the electrodiagnostic evaluation can tell us if that phone is ringing or not. The pictures cannot tell us that. So those are some of the common diagnostic tools that we use in determining the cause of chronic back pain. And I don't want to forget to mention the most important diagnostic tool, which is simply just taking a good history, listening to the patient, and then performing a thorough examination. The history and physical examination are really the most important tools. The diagnostic imaging and electrodiagnostic studies are just an extension of our history physical examination.
And the old adage is, listen to the patient, they're telling you what's wrong. So that's what he means by giving a good history, and we depend a lot on what is said. Given the diagnostic studies, and of course there's a variety of things that you might run into, obviously people want to avoid surgical procedures, and there are currently some very minimally invasive diagnostic and therapeutic procedures that can be done. Can you kind of approach this patient from that point of view? I'm not going to this OR, I don't want it. What can you do for me?
Well, I'm glad you asked me that, because that really is my specialty, that's my field. My goal as a physiatrist is to try to decrease or get rid of your symptoms without surgery. And the most powerful tools that I use are performed in a suite where we have a machine called fluoroscopy, which is a live X-ray. And we call these minimally invasive spine injections. And we call them minimally invasive because there's no cutting, there's no surgery. We just use small needles. And we use these needles to both diagnose the cause of pain and treat it, sometimes at the same time. Let me be more specific. I mentioned earlier in our first section that the small joints in our spine, the facet joints here, cause 40% of chronic low back pain. And most of the time it's due to arthritis or degenerative changes in these joints. So what we do is we bring a patient into our surgical suite, and under live X-ray, after we give the patient what I call happy juice to make it not hurt, we numb up the skin, and I place a needle in the joint, and I inject numbing medicine in the joint, and then an intermediate to long-acting steroid in the joint. And most of the time our research tells us, and our physical exam also tells us, that the pain is elicited from the bottom two joints. Sometimes on the left side, sometimes on the right side, but nonetheless, it's from these joints. And if we inject a mediator of inflammation, we can stop these joints from hurting. So that's one of the procedures that I use to both diagnose and treat chronic spine pain. We'll stay on the joint cause of back pain for a moment. And I mentioned that there's a big joint called the sacroiliac joint, or SI joint, and we do the same thing with this joint. This joint can become hypermobile and cause pain. I take a needle under live x-ray, I numb up the skin and then the joint so it does not hurt, and I inject intermediate to long-acting steroids in the joints, which should stop it from hurting for an extended period of time.
By
Now,
steroids, you mean cortisone products, right?
Cortisone products, yes.
Okay, all right.
Yeah. And we find that if we can stop these joints from hurting, then we can train the patient on how to avoid aggravating these joints. And often this is done with the help of physical therapy. And we train the patient how to unload the joints. Now, another procedure that we commonly do is the epidural injection. And in fact, there's not just one type of epidural injection, there's many different types. If we come back to the model, we have these spaces between the bones in the back, and this space is called the interlaminar space. And the old-fashioned way of doing an epidural injection would be to bend the patient over and put a needle in here and inject numbing medicine and steroids. Some of you probably have had that procedure, and remember that it can be a little bit uncomfortable. So over the past 20 years, we've developed a much safer, more comfortable, and a more efficacious epidural. And that is, we take a needle into the side holes. And these holes, again, are called neural foramen. And the reason why this is safer and more efficacious is because it's right where our problem is. Most of the time, the problem is from the disc or the nerve. So what we can do is we can, under live x-ray, which makes it safer than the old-fashioned epidural because we can see what we're doing, I take a needle and I put it right here, and I inject numbing medicine again so it does not hurt, and then I inject the cortisone type medication on top of the nerve that's irritated or around the disc that's causing the pain. And this type of epidural is called a selective fluoroscopic guided transforaminal epidural. But in short, you can just say, yes, I had an epidural and it helped me. In the same region, we have these nerve roots. And sometimes the nerve roots themselves can be the source of pain. And in that case, we do what's called a selective nerve root block, which differs from the epidural just by about 1 centimeter. We move the needle over and we just inject the numbing medicine so it won't hurt, and then steroid medication on top of the nerve root. And it's a depot steroid. It's a steroid that's going to sit there in a powder-type form and prevent that nerve from irritating the surrounding tissues or sending signals up to the brain that says, owie, I have pain.
Well, this is an excellent description of what can be done without any major procedure. And I think maybe the viewers would like to know what the results are percentage-wise for this sort of thing.
Right. Well, using the minimally invasive spine approach, we get the majority, we improve the majority of our patients' pain. In fact, Johns Hopkins published a nice study about a year and a half ago, and they had 5,000 patients, or over 5,000 patients in this study. I think we looked, yeah, over 5,000 patients. And these were patients that had severe back pain associated with a disc herniation. Let me move this model over and show you. So these patients all had single-level disc herniations like this, irritating a nerve root and causing back pain, and most of the time leg pain. Half the patients, they said, why don't you go and have surgery? have a surgeon remove this disc herniation. And in fact, at the 12-month period of time, they had 90% success rate. So at 12 months, 90% of the patients said, that went great, I'm glad I had the surgery. While the other group, we had them do non-operative management, which is what I do, these minimally invasive injections. And on average, these patients had 2 of these epidurals and 3 months of physical therapy, and they had 90% success rate. At 12 months, 90% said, I feel great, I'm glad I did not have surgery, thank you.
Well, that is terrific, and we certainly do appreciate your discussion today. This has been a very different approach, so we thank you, and I hope we can have you back again. There's more to say about back pain, I'm sure.
I'd be happy to. Thanks, Dr. McCabe.
You're quite welcome. Thank you for watching. Stay tuned to keep informed.